Let's pick it up from here and talk about presentation and diagnosis of adult ADD or ADHD in primary care. ADD or ADHD is considered a primarily neurological condition with a 75% genetic contribution. I prefer to call it a condition rather than a mental illness or disease, even though it is in the DSM-5 and you will be managing it along the same principles as other illnesses. Some argue that the milder form of the condition is actually adaptive for some situations in which humans evolved, but not so much for modern institutions like the classroom or a 9-to-5 job. ADD is not a joke. It can have significant impact on relationships, on work or school success, and risk of motor vehicle accidents due to inattention. So when you're asking about seatbelt use, think about whether your patient might have an inattention condition which might also endanger them. As you probably know, the DSM-5 recognizes subcategories of primarily inattentive, primarily hyperactive impulsive, or combined. Most adults you encounter are going to have the primarily inattentive subtype, and the treatment is the same for all subtypes. You will definitely see more adult men than women with the condition, with a ratio of about 2-to-1 males to females. There are 3 ways ADD or ADHD can show up among your adult patients. The first way is that the patient was given the diagnosis previously and already has a working treatment plan. This is common among new young adult patients who are graduating from pediatric care. You might hear a line like, "I take Adderall XR, 30 milligrams QAM. Can you continue that for me?" Ideally, you can obtain from them a previous medical record or a letter from the prior psychiatrist documenting the diagnosis and past med trials and the current treatment plan. If they don't have the documentation, it is reasonable to give them the benefit of the doubt for 30 days while they get that to you or while you follow up with the prior treater. The second kind of presentation is an adult who comes up with the question on their own without any prior treatment. The role play was an example of this. The patient opened the conversation by describing an affected coworker and noticing that he had similar difficulties as herself. In the example here, the patient says, "My son takes Ritalin and I never seem to get stuff done." Lastly, it might not occur to the patient, but you as the PCP might notice. If a patient is consistently late, poorly focused, or tells stories that remind you of other adult patients with ADD, consider the diagnosis. Now, how to diagnose? Officially, the DSM-5 criteria define whether someone has the condition. Like other DSM-5 definitions, there are lists for the subtypes, and the patient has to have a certain number of positive, and it's a judgment call whether each one applies. This is one option. Another approach is a semi-structured interview. That's what I did in my role play with Anjanette. The advantage of the semi-structured interview is that it maximizes your rapport with the patient and builds the doctor-patient relationship. The interview can also catch conditions that might screen as negative now because the patient has learned to compensate for them. But in my view, still support that the patient has the underlying condition. However, this approach is something you are likely to develop and use only after you become more familiar with the condition in adults. Most of the time, most of you will probably use a screening tool. A good one, which has been validated and which we have in EPIC, is the Adult ADHD Self-Report Scale, or ASRS. This is the questionnaire that you got a glimpse of at the very end of the role play. It has 2 parts, a part A which has 6 screening questions and a part B which lists 12 other common symptoms which can be used for monitoring progress. And you can see here how to access it in EPIC. We will look at the ASRS in more detail in just a moment. There are two other options for diagnosis. Of course, you can refer out to outpatient psychiatry. If you do this, keep in mind it can take up to a few months to find an available psychiatrist. And managing the insurance and everything else might ironically be extra hard for someone with ADD. So you will want to plan ahead for how you will follow what is their treatment plan if the psychiatrist is not on EPIC, and also how communication will occur. And lastly, neuropsych testing. Neuropsych testing will pick up ADD if the patient has it. However, insurance will not cover a neuropsych test if the only indication is rule out ADD. Sometimes if you are seeking the testing for other reasons, ADD will show up as a secondary finding. So let's have a look at the ASRS. Here is part A. The patient declares whether each experience listed applies to them as never, rarely, sometimes, often, or very often. If they score 4 or more in the shaded zone, that is considered high probability that they have the diagnosis. This is the rapid and efficient way to document something which justifies giving patient a trial of a stimulant medication. And let's have a look at part B. The patient answers similarly about 12 more common experiences in ADD, but they are not part of the diagnostic question set. Keep track of these answers, though, in your chart, because those in the gray boxes will tell you your target symptoms that you are looking to improve via treatment. And lastly, here is a brief differential diagnosis. Some medical conditions may include agitation or restlessness, but remember that ADHD will be patient's baseline, and it must apply in multiple life contexts. If it is ADHD, some version of it will have been present since childhood. Some other psychiatric conditions overlap with ADHD, as shown here. Each of them has some features in common with ADD, which I've listed in parentheses, but other aspects not. The mood disorders are usually easy to distinguish because they will be time limited rather than the patient's whole life baseline. Finally, the patient might well have both ADD and another psychiatric condition. So keep this in mind when you hear symptoms that could fit into multiple diagnoses. That concludes part 1. Part 2 will look at how to initiate, monitor, and manage stimulant medication once you have established a diagnosis or likely diagnosis of adult ADD or ADHD.